online. Good morning, everybody. I think I know most of you from last time, but I'm Catherine Grayling, so I'm Director of People, Culture and OD in the NENC ICB. Gosh, all the acronyms. But I also lead on Boost the Learning Improvement Communities, which I think most of you know now. So welcome to our Discharge and Safe Transfers of Care collaborative meeting this morning. We have got a packed day, and I'm just going to load the presentation up and then we'll make a start. Just takes a couple of minutes. Hopefully, although my computer's going crazy at the minute, so. Here we go. Who doesn't love a few computer gremlins first thing in the morning? Okay. So at our last session then, we spent a little bit of time exploring Boost and what that means for us as our umbrella for this collaborative. We reflected on what the collaborative has achieved to date, and we launched the retro board so that we could collectively view on our themes to focus on going forwards. And the result of that retro board was that we wanted to do more detailed work around the role of the third sector. We wanted to do work and understand more the methodologies behind virtual wards or hospital at home. And we wanted to explore the impact of drug changes on discharge. So what we've done today is we've based our content on that from that retro board output. And we're delighted to invite Paul, which I'm sure you all know, Paul Carruthers, Transfer of Care Hub Manager from NCIC Foundation Trust. And Paul's going to be talking to us about co-production and delivery of the discharge to assess pathway, supporting safer transfers of care and ensuring to promote a home first approach. We're going to follow that with some breakout rooms, and we're going to be discussing whether in your area you're already operating a true discharge to assess pathway, and if not, how could you utilise the third sector? So that's what you'll be thinking about whilst Paul's giving his presentation. And then we're delighted to welcome Tom Dunkerton, the Commissioning Manager in the North East North Cumbria ICB, and Daniel Cowie, a GP and Ageing Well lead from the ICB as well, to talk to us a little bit more about the virtual wards as an integrated urgent and emergency care system, how we might approach that. And they're going to just be taking us through some of the early thinking, because the proposal is that the ICB is doing some work on this at the moment, and we would like you to have that opportunity to gain a level understanding about what that means, so that you can input into the future development of that work as we move forwards together. So that's what we're going to be running through today. So I'm going to hand straight over to Paul, because we've got quite a bit to get through and I want to make sure we've got plenty of time for our discussions around this. So Paul, welcome to the meeting, and over to you. Thank you very much. I'll move the slides along if required.
Yeah, no, that's grand. Thank you very much. So I think today, let's say, before I kind of delve into the presentation, you know, we're very proud at NCIC and North Cumbria. It's not just an NCIC kind of element. This is a system approach of what we've achieved. But I do always caveat that to say that we certainly haven't got it perfect. So it's around, you know, we've still got lots of things to achieve and quite a long way to go. But through some of the work that we've done over the last kind of 2 to 3 years, we've really started to see some more effective discharge pathways, which are really starting to support better patient outcomes, improving flow, and also improving patient experiences as well. So I think if we go to the first slide. Like I say, this is the co-production and delivery of D2A pathways, supporting safer transfers of care and ensuring to promote a home-first approach. Like I say, this is not just an NCIC model. This is co-produced with our system partners, which also includes our third sector services as well. So if we go to the next slide, so just kind of working a little bit backwards, so kind of going to the end of the story. So here is some key kind of metrics that we've been able to kind of evidence with utilising A, discharge to assess, but B, the transfer of care hub in that position. So we've had 0 CHC assessments conducted within the acute since 2021. We've seen as much as a 50% reduction of initial domiciliary care prescription when the patient's assessed in their own home, as opposed to on a ward. We've seen more than a 40% reduction of delayed discharge patients within acute sites since the implementation of D2A in 2021. So we had quite large numbers, and at the moment, you know, we are kind of seeing higher than normal with the kind of usual winter pressures that we're seeing. But let's say even so, it's still lower than what it was back in 2021. We've got less than 25 adult social care assessments conducted within the acute setting since 2021. We do some where it's kind of appropriate to do so, and where we might feel that it might speed up support that kind of flow. But we do try to promote that happens outside of the acute and community hospitals. 14 acute bed days saved on average when care assessments take place outside of the acute setting. So when we look at what it was like pre-COVID and back in the DTOC days, where we used to have to, patient would become at that time medically optimised, now discharge ready. We would then put our referral into the local authority. They would have, I think it was about 72 hours to come back to us. Assessments would start to take place. You would then have to get it into the funding meeting, which I think happened twice a week, and then after that you would then start to look for a package of care, and on average we calculated that to be around 14 days, sometimes much longer, sometimes a little bit less. 47% reduction in over-reliance of pathway 3 step-down beds since the introduction of D2A, and that's something that we really try to push for. If a patient is on a set pathway, whether it's 1, 2 or 3, we don't then start putting pathway 1 patients into pathway 3 settings just to support flow, because we know it has a negative impact on patient outcomes, and that's really important for us. So we have live reporting, so we're able to track daily discharge metrics. We've built an in-house system called Patient Vision, which is now, I think, accessed by over 2,000 users across the health and social care system. It's not our place for recording like legal documentation, but it's a snapshot of where each part of the system is at with that person. So at any time, you know, you can have a bit of an idea of where someone's at. Really reduces kind of telephone traffic and email traffic, and it means that we're all working off one list. So it's that one version of the truth. More than 300 discharges supported by commissioned third sector services. Again, a huge part. It's probably gone up quite a lot now since that figure was put in there. Yeah, by commissioning some third sector services, we've really seen support within our kind of ability to discharge. And we have a 7-day transfer of care hub service, so we're working over the 7 days. So going into the next slide. This is North Cumbria's kind of transfer of care hub model. So we have a director of discharge to assess and home first. He's on the call today, that's Peter Moore. We then have myself as the transfer of care hub manager, and both Peter and I have are kind of employed in the same way. I'm a nurse by background, but I'm it's a system role, so I'm employed by the local authority, the ICB and the NHS. So that's allowing me to have a foot in each of everyone's camp, to support each other, to support each of the organisations, but also to hold the mirror up to each organisation when things maybe just need to be reviewed a little bit and try and think of a different way or a different approach. Within the hubs, so we have 2 acute sites and a number of community hospitals. Now we have a transfer of care hub on the one transfer care hub each for the 2 acute sites, and then we have a transfer care hub which kind of works across all of the community hospitals. And across all of that, we have one lead therapist, so they're a band 7, so band 7 lead therapist. I have 2 band 7 lead nurses, and we have 2 hospital-based social workers across the 2 acute sites. We have a discharge nurse, 4 discharge nurse coordinators, so they're a band 6 nurse. We have 5 trusted assessors, so they work, they're actually employed by the local authority, and what their role is to set up all pathway 1 discharge to assesses for that go via the social care services. And we at the time of this, it's kind of changed recently, but we had 1.5 FTE of third sector coordinators as well within the system. We also have some other services outside of the system, which again are which we'll get into, which is our commissioned third sector services, but they don't sit within the hub. They're very much part of the hub as an extension, but they're not within the hub's kind of framework. We have 20 we have 20 FTE of discharge navigators. They're currently a band 3, but are looking at kind of a bit of a band review but on those, and they are our hunter-gatherers of information. They're our absolute salt of the earth. Without them, we wouldn't be able to do what we do, but they're embedded on every ward within our acute services, and they basically attend all of the board meetings. They're not clinical, but they gather all the information and feed it into the team so that we can use that information in real time to support with plans. And we have 2 now 3 team admin support, so that's kind of some clerical support, and as the key on the bottom just identifies kind of the different organisations that they're from. If we move into the next slide. So the transfer care hub, so it's took a long time to get us to a position where we're not just the handoff for everything that has the word discharge in its title. We're really kind of clear about that. So we are a multidisciplinary and an interdisciplinary discharge team, and the reason why we put the interdisciplinary team is during a weekend or during the week, although the nurse might not be able to do all of the roles of the social worker, they have a very good understanding, quite cohorted in their roles. Again, the transfer care hub was co-produced. It wasn't something that we just did from an acute. It was built from the ground up using all system partners being part of that, which I think has been quite key to its kind of its current success. And the idea of the transfer care hub is to have that pull approach. So we're not just sitting waiting for referrals to come in. We're constantly pulling people from the different areas and making sure that we're kind of evaluating what their kind of discharge pathway has been set at, checking it's correct, and then supporting with the plans to get those plans in place before handing those plans back to wherever the ward is. And then it's the ward's responsibility to then discharge that patient safely in a physical kind of context. The transfer care hub predominantly takes on responsibility for pathways 1, 2, and 3. We very rarely get involved with pathway 0 patients unless there's something quite specific that we can help with, and that's because that's recognised as responsibility for the wards to support. They don't need any health or social care support outside of the hospital. Everything within the 4 walls of the hospital should be able to support that patient home. And then once all the kind of, like I was saying before, once all the arrangements have been kind of supported by the transfer care hub, it's then, let's say, handed back to that ward to safely execute a safe and timely discharge into that package that we've supported, or whatever that might be. Next slide, please. Discharge to assess. So again, another thing that we're very proud of in North Cumbria. So we have got a very pure approach to discharge to assess, and we have it across all of our pathways. The D2A budget for a lot of our services has been drawn down from the Better Care Fund, and that provides up to 4 weeks of funded interim home care or 24-hour residential/nursing care, whilst we then start to do care act assessments and, if possible, or if required, CHC assessments. And within that time frame, we're hoping to have had all of those things done. It does go over sometimes, depending on where the person is or how complex they are, but then they're then handed over to a long-term care provider. But by doing it this way, we're able to really right-size that care so that we're not over-utilising the private care agencies in the market, so that we've got more care hours to give to more people. Pathway 1, so the way that works is we've got a bespoke transport service which we've commissioned just for our transfer of care hub, because the current service just didn't have the SLAs that we needed. The patient is arranged by the transfer of care hub to have their discharge to assess, and they might either go on a health or a social care D2A. If it's health, it's because they've predominantly got therapy or complex nursing needs, which are kind of picked up by our therapy teams in our NCIC community hubs. If it's predominantly more that someone has a social need, it would go through our social care pathways, and that is through our adult social care's reablement service. So what happens is there's a lot of work done from the hub to get those arranged on for a day for that to happen. We're normally booking in today's for tomorrow. So it's kind of that within that 24-hour period. And the idea for that is once the patient has kind of had a booking, they'll be picked up from the ward at a set time by our private provider, transport provider, taken home, and as they get home, they'll be met at the door by either a therapist from a ICC hubs or by a reablement review officer from adult social care. They will have their assessment completed in their home. It usually takes about 1 to 2 hours. And in that time, it will be identified, do they need any interim support? Do they need any equipment? Do they need any other kind of specialist support as well in there? They will then source that the care that's required, the interim care, and put those bits of provision in place. If the person doesn't have isn't safe to be at home, the safety net for that is that we'll try and kind of step back up into another setting. So that might be into one of our community hospitals, into our 24-hour interim intermediate care service, or if needs be, back to the acute hospital. And a lot of the time people think, well, that's a bit of a backwards way of approach, but actually those patients would have waited a lot longer to go out. But when they do come back, we don't call it a failed discharge to assess, it's a return discharge to assess, because we've learned what that person needs or why they're not safe in their own setting, which means that we can then start getting the teams right onto that from the transfer of care hub to source that whatever it is that's needed to support that back out, that patient to go back out. And consistently since doing discharge to assess since kind of 2021, we've had about a 10% return rate consistently. So it's very small numbers. Pathway 2, let's say that's predominantly into our community hospitals, but we've now set up a number of intermediate care service beds within our local authorities' care home beds. So they're individual rooms on a unit usually. It's health therapists that run that service, but there is other services that kind of support. And the idea for that is it's not about going into a 24-hour residential care where everything's done for you. It's that reablement approach, and it's usually those patients that go into like the likes of the intermediate care service beds, which are getting to the point where they might not be able to be supported at home. We haven't maybe got all of the things in place to get them home, or we need to do some ongoing assessments, but they don't need to be in an acute hospital. So in there, they will have regular therapy. They've got kitchenettes that they can go and make their own cups of tea and promote to do that, their own room. And it just gives us a different setting, a bit more of a realistic residential setting than what we might find in our community hospitals. Community hospitals predominantly for people that have ongoing complex rehabilitation needs that need that 24-hour care. And then as for pathway 3, like I say, patients will always go into a pathway 3 setting if they genuinely need that. And we've got quite a stringent approach about how those patients would access that. And if once they go into the private care provider, they're funded on 4 weeks worth of discharge to assess funding, and at the end of and during that period they will then have their assessments, as I was kind of explaining in the piece before, and once that's kind of all been completed, the person is then handed over to a private provider. Usually, if we've got it right, and most times we do, the placement that they go to is where they then stay, unless they've got a specific decision to go somewhere else. What we're very clear about, because it is 4 weeks D2A funding, we do try our hardest to get patients' preference where possible, but if that's not available in a timely manner, patients are expected and informed that you will need to move to the next available slot that can safely meet your needs, but we will look to get you to where you want to be once assessments have completed. So it's not about you can't go into that bed because you don't want to. The hospital bed can't be your second option when there is an available safe option there to move into. Next slide, please. This is a huge part of the process. So maximising the third sector capacity to improve patient flow. So a lot of the time when I first started in this role as a transfer of care hub manager or a discharge lead to begin with, I often used to get asked around, why aren't you using the third sector as much? And I used to keep having to wrap my brains about why we weren't. And at the time, it was very much we were trying to utilise free services based on volunteer kind of support, and then get frustrated that they weren't working at the same pace as us, but they were never going to be. These are people spending, offering their time when they could. So we might need it tomorrow, but they couldn't get someone for 2 days. So what we did over a period of time is we explained to the third sector services, these are our issues. We've got a bit of money here to kind of commission some interim services. Can you give us a bit of a service spec on how you would support our needs, rather than trying to dictate to them what it is that we want them to do? And they did it. They fixed, they would come, they were very clear on how they were going to achieve these things, and we've really now started to work forward. And I think we've now got a very clear core service. We would like to do much more, but obviously that requires lots more capital. But some of the key systems that we've got in place. Oh, I've got a bit of feedback there, sorry. Is key safe installation. Huge thing that puts loads of delay on. So if they can't get the key safe fitted in advance, they'll make sure that there's a temporary key safe installed to prevent delay to discharge. Once the person's home, they'll then go and get that key safe, the more official key safe put on, and then bring that temporary key safe back into circulation. Telecare support, we've got temporary telecare devices which support us to get faster discharges out. They not only support in making sure the devices get back, they also support families with how to use them, making sure that the responders on them are, the people that are responding understand the process and have that holistic support within those areas, because it can be quite complex. Deep clean service, again, people that come into the houses which have maybe been struggling for some time, the house has got into such a state that we can't actually put a care service in there because it's a hazardous space for working. They will go in, they'll do the deep cleans. If it's got to a point where it's way past their kind of threshold, which, to be fair to them, they do clean up some quite severe settings, they will do the onward referral to places like Department of Health and places like that, and manage that for us and keep feeding back to the hub, so that that's kind of not referred to them and then they refer back because they can't do it. They've got a trusted assessor service, so making sure that if people need bits of equipment, they can assess for that and fit it. They've got a care to move service, so that's about trying to keep people mobile, getting them to access different kind of day services, and an access to food service. So when people have maybe been sent home on a discharge to assess, or when these guys have been involved from a third sector perspective, making sure that they've got ability to get the right benefits in place, and then maybe accessing things like Meals on Wheels and other services if needs be, or supporting with some shopping, getting onto online shopping, and trying to kind of make sure that they've got that kind of provision to support them. Again, benefit and housing support, making sure they're on the right benefits. That again helps with like heating, all of those allowances, making sure that they're getting everything that they require to keep them safe at home. They've got the community social inclusion services. Again, that's about trying to get them into like local kind of community events to try and keep their kind of socializing, from a mental health space, and keeping them connected to services. And then that initial resettlement support. So someone's been at home in hospital for quite some time, they're going home, they maybe don't need any official care needs, but making sure that the boiler's switched on, making sure that all the taps are working, there's been no bus taps and things like that, but really just making sure that we're preventing delay to discharge, but providing that much more holistic support, which our health and social care services often just don't have the time to really kind of get really involved with. So let's say a huge part of our service, and we do see them as a system partner. That it's not a small mean feat. They are crucial to discharge. Next slide, please. Maximising it moving forward. So 2024 vision, I've had this vision quite some time and trying to kind of work it through, but the idea is often or not we have small pots of money come through at different times, and we try and utilise that as quick as we can. But it means that the third sector often get kind of short contracts they just start to get up and running, they just start to get embedded, and then all of a sudden that kind of money's gone, and then it's kind of trying to purpose those staff. We want to better utilise our Better Care Fund and try and really bolster the third sector to have some real core services that are a bit more kind of, officially kind of in the budget pot. But again, rather than having something kind of set up where each third sector organisation is doing something slightly different, but the referrer, whether you're a GP, a nurse on the ward, or whoever it might be, having to keep yourself abreast with all of the kind of criteria, where they're working out of. A lot of the time, by the time someone's got cottoned on, they ring in for it and it's been closed down. So the idea is to try and have a third sector single point of access, so some specialists who absolutely, and we do have that to a certain extent now, but we want to expand on it, where anyone from any part of the system could contact that third sector service. They will know exactly who's doing what in what area and support that onward referral, so that we can absolutely maximise all of the systems that we have in place, but also to capture data around what we're maybe not commissioning that we're using lots of, which with a bit more money could actually really improve patient flow and better outcomes for patients. Again, we're not there yet, but that's what we're trying to work towards, certainly in 2024. Next slide. So last kind of slide for me on this one. So key enablers to support the success. So it was an encouraging a no place like home culture all the time. So like I was saying before, yes, people might have had quite complex kind of experiences at home prior to coming into hospital, but just because it's been hard work, if there's no evidence that health or social care have been involved or there's been any assessments, it's not always about family maybe struggling and therefore we go straight to pathway 3. It's always about, let's get you home, let's do the assessments there. We're not saying that a 24-hour bed isn't appropriate at some point, but let's get you home and get those assessments done. Maximising the third sector capacity. Clearly articulating the vision to all system partners, so setting clear objectives and estimated timelines, so we're working towards kind of, system goals. Co-produce services, so if a service is requiring different elements, make sure that everyone's at the table to begin with, and helping to build that and believe in it. Determining your roles and responsibilities within the transfer of care hub. So where does the transfer of care hub start and where does it end from a responsibility perspective? Otherwise, you do fall into the risk of being there for absolutely every escalation that comes in, and it's keeping your boundaries, which kind of goes on to the next point. Avoid disempowerment to the ward staff. So again, yes, we're here as a support service, but when we're not here, things still need to happen. So it's about keeping that kind of two-way flow going. Ensure each part of the system understands and agrees the process. So we're working through currently, we've got a system, a co-produced by the system transfer of care policy now, which kind of replaces the discharge policy, but we're now working through a lot of the kind of appendices within that. So that's the pathway 1, 2 and 3 kind of standard operating procedures. So people are really clear of what that looks like and whose roles what within that system. Ensure to build a mechanism which supports daily communications with system partners. So we've got a flow call every day in our two hubs. It's about an hour. We use our patient vision, so we're working through one set of data, and we make sure that every day, you might not have a discharge date for the discharge ready patients, but every person has got a plan being worked through day by day, setting actions, checking actions, and pushing that forward, so that we're making sure that people aren't kind of just being forgotten about. Start discussions regarding discharge from point of admission. Again, so we've got a bit of a work with our navigator, one of our navigators at the front door. They're kind of collecting as much information. Have you got a care package? Yes. Who's it with? Are they going to take you on when you come back out? So we're starting to pick that stuff up at the point of admission, not once they're discharge ready. Really getting that information picked up, any safeguarding issues from NWAS or anywhere else, and really starting to feed the system partners with the information from as soon as we know it. Single version of the truth. That's our patient vision system, and this is a big one. We don't ever describe. We try to describe a person. We never prescribe. So when we're doing discharge to assess, for example, for pathway 1, we would never say we think this person's going to need 3 calls, and then we have to wait for interim services to have 3 calls available. We never do that, because we know when the person goes home, it's most likely they'll either need more or they'll need less. It'll never be really what we've asked for. The only time when we do be a bit more prescriptive is when we know that they're a double up patient and they're going to an area where we know has minus capacity, because that would just be a little bit of a it would create a lot of issues in that sense. But yeah, describe, not prescribe. And then utilising the available capacity within the third sector, which I think I kind of mentioned above. And lastly, to understand that true integration requires compromise from each system partner and recognising each other's pressures, which I think is huge. We often get into that trap of we're health, we're social, but actually the person in the middle is very intertwined with health and social issues going on at the same time. And if we're both working in our own silos, they often feel like they're being pulled in two different directions. So again, having that system working. And that is kind of our hub in a very quick nutshell. I hope that was okay. I'm open to questions, but obviously I don't know from time constraints if.
Thanks, Paul. I think we have got a couple of minutes for a few questions before we go into breakouts, where hopefully there'll be some really rich discussion around this. But firstly, thanks for coming to present today. Such rich and detailed work, and I think what struck me was the huge culture piece that you've done sitting behind this programme. I mean, avoiding disempowerment of staff, that culture of learning rather than failure in the pathway, framing the problem with third sector and inviting contribution rather than dictating, and describing that real personalised approach for patients as well, and being very inclusive around that. So I'll open it up now if anybody does have any questions directly for Paul, and following that we'll move into our breakout rooms. Claire.
I think just for those who don't know me, my name's Claire Edwards. I'm Health Partnerships Manager at Cumbria Council for Voluntary Service. So I link the third sector and health and care here in North Cumbria, or try to. I just really a couple of comments just to add to some of the stuff that Paul said. We really are very much in the early stages, and we've really welcomed the opportunity to work much more with our health and social care colleagues around discharge. But there are some key kind of structural problems that really do trip us up endlessly. And one of those is the flow of finance. And I can't stress this enough. And I know Paul is as frustrated as we are in the third sector. Funding comes in dribs and drabs, never ever more than 12 months at a time. And that makes it really difficult, because every point at which funding comes and goes, we are having to renegotiate, and that takes up huge amounts of capacity, both from the system's point of view, Paul's point of view, Peter's point of view, but also from the third sector's point of view. It makes it really difficult for the third sector to plan and to retain staff. There are other things I want to say, but I'll perhaps save those for some of the workshops. But just to say that we are battling against some real structural issues that I think it's really important to raise at North East North Cumbria ICB level, rather than being able to raise and solve at a North Cumbria level. And Paul, I hope that's fair.
Thanks. Paul, is there anything you want to add to that?
No, I think yeah, Claire. I say about work closely with Claire and stuff, but yeah, like I say, it is challenging. I think for the staff that work in those organisations, they do such a fab job, but they're always on this ticking time clock of when that contract's going to end. And in a time when we've not got enough workforce and we've got people willing to do things when they're really good at it, in fact, the experts at it, it's about trying to secure their position in the system.
Yeah, always a challenge, and I mean, we're fortunate today. We've got colleagues from our commissioning part of the organisation and from NHS England as well, and I think we do have a role in continuing to try and influence this. Any other questions or comments before we move into breakouts? I can't see any hands.
Actually,
but
I've
yes.
got my hand up. I'm Sam.
Oh, apologies.
And I work in the Newcastle Place team in the ICB, and thought that was a brilliant presentation. I was just really curious with the sort of the services that you have got provided by the third sector at the minute. Is it one organisation providing all of those, or is it many?
it kind of feeds from the conversation that we've had then. Predominantly at the moment, it's one. It's Age UK Well at Home service who provide the kind of hands-on approach. Cumbria CVS have got a third sector service kind of approach, but like I say, due to funding and stuff, it's quite a small team and they're kind of covering a wide area. So obviously there is a limitation to what they can do, but they never say no. But we're conscious that there's an element of needing to protect them from being overloaded. But over the last year or two, when bits of money came in, it was like, you've got this money, but you've only got this week to spend it. We would kind of have, in the words of Boris Johnson, which kind of is not very maybe great, but oven ready style kind of services which we can quickly enact with that money. So we're trying to bring more of the third sector services in, but we've come to a point at the end of this year where we've just kind of run out of money. But we've had multiple services in at one point, which was great. We were covering, just one of them was around kind of patients that are in hospital or kind of community hospital beds, just a bit of general phys. So pulling bands around, and it sounds on the face of it not that great, but actually it keep people moving. They were engaged with it. They were engaged with conversation. I would go into homes and people would be saying, "Oh, Paul, I'm still doing my bands," or whatever. But it was just connecting them with their kind of recovery, really.
And just on the back of that, you mentioned that you sort of went to your third sector partners with the problems you had. How did you have those conversations? Was there a forum where you could take that to open up those conversations?
Well, I think it's fair to say they were not quiet in knocking on the door. They were kind of shouting up, saying, we're here. So I was lucky in that sense. I didn't have to kind of go searching. But I think it just took, once we got into the mindset as an organisation that the way we were going to tackle this is like having a co-produced system partner, not just kind of your list, my list, but working together. I think that opened up that discussion. Obviously, I think Claire's probably been in this system much longer than I have, and probably could answer that maybe for you. But yes, there was places we could have those discussions to begin with.
Can I just add to that, Catherine, if that's okay?
Just
really to say the model that we have pretty much exclusively used, Samantha, is to work with our colleagues in the Community Foundation here in Cumbria. So we have placed pots of money to produce a hospital discharge grants programme. And we have asked organisations to come forward with their kind of ideas and suggestions. And we have ran the programme as a donor advised programme with people from different parts of our system here in North Cumbria, but obviously heavily around the NHS, to look at all of the applications that came forward and pick out the most appropriate ones. The problem that we have had is that injections of funding have been, as Paul suggested, often short-lived. So being able to pick up the best of those projects has been difficult. I think also what we have had is a strong approach that is the programme or the applications that were successful. We've continued to modify those. So it hasn't just been we're delivering what was in the application, we're delivering what's in the application as a starting point, and then connection with Paul and his team and other parts of the system may then continue to modify and develop some of those activities. But yeah, we've got a stable of really great projects, not all of which we've been able to continue to fund, and it is a bit of a tragedy. So we had a 24/7 end of life helpline managed by one of our hospices, the project that Paul talked about, which was ward-based services provided by activity coordinators based in the third sector, which provided social support as well as keeping people active whilst they're waiting for Discharge, Meals on Wheels provided support for people over a 4-week period who were struggling with kind of sort of food poverty and or food issues on their discharge from hospital. So a whole range of different, and our carers support service, which specifically work with unpaid carers to help them navigate the discharge process. And few of those we've been able to continue to fund. Sorry, I'm taking up way too much time.
Really helpful.
Thanks, Claire. Okay, so in the essence of time, we're going to move into breakouts now, and you know we'll have that opportunity to get under some of these discussion points a little bit more. So Ashley's going to move us in, but it would be helpful if you'd consider the following questions. So in your area, are you operating a true discharge to assess pathway already? If not, how could you utilise the third sector? We will post these into your chats. How are you closing the loop at the minute, or how are you collecting the data, and are there any improvements that can be made? So just some opportunity to share. It would be really good if you could summarise, so if you can pick someone in the group who would be kind enough to volunteer to summarise the discussion and just feedback for a few minutes when we come back together for the second half of the session. So bear with us and we will just pop you into your breakout rooms now. Hi everyone, welcome back. Hopefully you've all had chance to have some good discussion around this topic. I know it's always preferable to have more time, but we are bound by the hour and a half we've got allotted to this meeting. If we could just perhaps take one or two at maximum points from each group, if you've got something to share, that would be really great. So if somebody can volunteer from each group just to share some of the feedback from your conversation. Paul.
Yeah, so obviously I just did a bit of listening in there rather than kind of talking, which is a first for me. But I think the point that we managed to kind of get across is it sounds like in most areas, if not all areas, certainly transfer of care hub models certainly kind of either in place or developing quite well. It sounds like there's a bit of a mix around third sector, so some people have got third sector services in, some people haven't but have got plans to, and some people are kind of at their early stages. We also had colleagues from kind of external services and third party, again just that conversation about funding, you know, for third sector services, but also from Jane from as the Better Care Fund manager, just saying that, you know, there is some money in the budget, and obviously that's going to be kind of reviewed quite shortly to see exactly what's kind of there. But yeah, overall it sounds like most people are either there or certainly got plans to start.
Thanks, Paul. Any of the other groups? Michael, please.
Thanks. A few points from us. Firstly, transfer of care hubs operating across the areas that we talked about, but the situational, so how they operate depends on how services are commissioned, what kind of provision there is within the commissioning frameworks. Big topic about funding and continuity and stability of funding, and also about how transfer of care hubs can expand their role into working with some of the most complex people, particularly people who are homeless, who are in and out of A&E, in and out of acute medical beds, but whose access to stable accommodation would probably prevent an admission and therefore make their lives as individuals better. And I think the final point was, we had Patrick on, who's one of our patient reps, who was saying that question about stability of funding comes up persistently in all of the groups in which he is a member. And it does tend to influence adversely the way that our transfer of care hubs work. Thanks, Catherine.
Thanks, Michael. And really hearing that theme around funding consistency. Anyone from the remaining groups? Judith, thank you.
Hi, yes. So again, it's really echoing what everybody else has said, how there's differences across the regions and across the areas. I explained, and I feel that I was probably the only person in my role. I was a lot with people from ICB and different areas who weren't actually in the hubs working. That I'm relatively new into post within Gateshead, and looking at the structure and how we got to develop. We've got very good foundation, very much set up, but yes, there's a lot of development. It depends on funding, and it looks at how we work together in partnership.
Thank you. I believe I've got one further group. Michael, you've still got your hand up. Did you want to come back in, or just right? Okay. Anyone from that final group, or have your points been covered already? Okay, I shall take your silence as the answer. Thank you very much. Ashley, are you ready to share the presentation again? And we're going to move on to the second part of the meeting now, and I'm hoping that Dan and Tom have been able to join us.
I'm here. Dan can't join us, I'm afraid, but
right.
I'm here, so I'll
okay.
try and do my best to cover for Dan as well.
Brilliant, thanks. Well, welcome, Tom. So everyone, this is Tom Dunkerton, and he's going to be talking to us about making the most of acute at home, so virtual wards in an integrated urgent and emergency care system. So welcome, Tom, and over to you. Thank you.
Well, first of all, I would just give a big thanks to invite me along. I wasn't aware of this group until last week, so I just have the opportunity to widen the conversation to a wide audience. I think it's a really, really good thing, and certainly I think we are going through that terminology about going through a journey, but I think we are, and the more we can start bringing people with us and getting more engagement and getting some insights will be really helpful. So this is a really good start for us, so thank you for that. What I don't know, of course, is how much knowledge is out there in terms of the virtual ward programme or in this meeting. Some of you will know quite a lot about it and probably know more than I do. And there'll be some that will be, well, we know of and we've heard about it, or we hear slightly different versions of it. So I think just to sort of kick off with, I think it's just worth sort of just on slide 1, if that's all right. So really just to cover a little bit about virtual wards, it's not a new concept at all. And I remember being in conversations as long ago as 2005, where we were talking about virtual wards. But what we're really talking about at the moment is since 2002, there's been a national funded programme, which is under the title of virtual wards. But prior to that, what you would find is a number of trusts would develop pathways like hospital at home services. It was very predominant in respiratory, and certainly it was become more sort of well known during the COVID period as well. So many of those hospital at home traditional type of models have morphed into the virtual ward. So you will hear different terminologies, and I think moving forward we really need to be clear to people about those definitions of virtual wards, because I do think that does cause some confusion. They are roughly the same thing. So just to go through that sort of slide there, you know, what you may get is models where there's a large emphasis on remote monitoring. And an example of that would be South Tyneside and Sunderland, who have a digital platform called Lucy, and they use that for their virtual ward programme. You will again have the traditional models that I've talked about, which is mostly face-to-face. But what I would say is they're starting to blend into a more sort of, while we're sort of getting to the point of being able to introduce digital technology enablement, they're starting to come more on the phone now about how they can really maximise the potential for virtual wards, but also support that sort of, if you like, opportunity for carers and patients to monitor their own vital signs, but with a digital platform sits behind it that could be monitored by a professional team. So virtual wards can be both step up, so that might be a patient who's been admitted into hospital, but actually their acute care could be supported and delivered at home, so will be stepped down to a virtual ward, or could be a step up, which would be rather than end up on a physical bed, could actually be cared for in their own home. So you've got both step up and step down. As part of the national programme, there was a big push for 2 key pathways, which was respiratory and frailty, which was not to restrict any other innovations in other pathways, but they were the 2 key ones that was the key focus. If we could just move to the next slide, please. So the virtual ward program is really underpinned by 9 key principles. I'm not going to go through them all now, they're on the screen, but I suppose there are a couple that I think stand out for me that I think might be quite useful just to highlight today. I think the safety and sustainability of virtual wards. I think certainly there's evidence starting to show now that virtual wards is actually a safe alternative to hospital care, although there are, you know, lots of concerns about risk management, about risk decision making. You know, ultimately the evidence suggests that it's actually safe for a number of particular reasons. I think the other thing to say in terms of the principle 2, consent and self-support, I think virtual wards lends it to, you know, we use the terms personalisation a lot and shared decision making and proactive care, and in many ways virtual wards lends itself to that because it changes the conversation between the clinician, the professional, the patient, and the carer as well, because the way virtual wards are operated. You know, it is virtual ward platform. There is potential use of technology through appliances and kits and wearables to monitor vital signs. So again, I think in terms of that consent and self-support, the conversation really needs to be very clear and explicit, and really, you know, that level of, I guess, comfort and security and reassurance is really, really important as well. And I guess the other sort of principle I'll be keen to sort of just highlight is about integrated service provision. So our current model has been very much based on being led by foundation trusts. Many of the pathways that were established were step-down pathways from hospital. What the evidence is starting to come clear, certainly in our model around North Tees, where they've been predominantly step up, and in other parts of the country where they've had more step up from primary care and other services, the outcomes are significantly higher. And ideally, if we can, you know, keep people from being in hospital but can get the right level of care needed, surely that's the good thing. But to do that, we really need an integrated approach. It needs to shift away from one domain and one dimension of one particular part of the health system, and it needs to be a lot more collaborative and cohesive to make that work. And that's really where we are today at the moment in terms of how we make that shift. Again, we've talked about digital inclusion, and I think that's really important. And again, I think the evidence is actually suggesting that where there's a digital interface, it does allow the opportunity to do more, if you like, low-key monitoring as well, which means you can actually have more people who maybe were being observed in the hospital bed can be observed at home, which means really you've got that opportunity for you know, more throughput for patients going through the virtual ward programs. Next slide, please. So I suppose it's just to sort of try and give some real sort of differentiation in terms of what a hospital at home or virtual ward is and what it isn't really. So we are talking very simply in the way that this is treatment, care and support that would have been delivered in a hospital setting, but with the right support and infrastructure and access to diagnostics and interventions such as IV could be delivered at home. What it isn't, it's not intended to be a hospital prevention program. It's not meant to be something that should be used to duplicate or compensate for other parts of the system that maybe are challenging at the moment. It really needs to be an integral part of an overall system approach and a safe alternative to hospital beds. It's not intended to again, it's not about community nursing or chronic disease management in terms of health maintenance. It's very much about that acute period of time up to a period of 14 days where treatment is required. Next slide, please. Right, there's one of the challenges I think around virtual wards, with it now being a formal program, there hasn't been huge amount of evidence around virtual wards, but that's starting to gain momentum now. Getting it right first time, I've undertaken quite a lot of work over the last year or so, looking at research studies and other evidence across programs within this country and other parts of the country about what is the evidence that actually sits behind virtual wards in terms of the benefits. So it is starting to come to the fore now, and I think it's really important that we can capture some of those things. I think the first thing to note, and it's certainly something I hear when I talk to our providers and teams who deliver virtual wards, is patients love it. Patients who are on the virtual ward program love it. It's safe. It's personalised. It feels that that the team's there for you. It's in your home, so it's comfortable. So in terms of the feedback, that's really positive. And I saw an interesting video that North Tees had done. Followed the team out to a patient, and the patient was being interviewed about her experience. And I think the term she used was she would rather knit. You've got more chance of knitting fog than getting her into a hospital. So I think her view really was a really positive experience. I think the other thing to point out in terms of patients' well-being and safety is that patients are 5 times less likely to acquire an infection. And we know, that is a significant risk, and particularly around our older, frail population, there's a huge risk around that. And in addition to that, patients 8 times less likely to experience functional decline. And we know that is a major issue if you are a person who goes to hospital, say, with multiple conditions, and you also feel as well the chances are you come out of hospital, your functional decline is going to decrease quite rapidly. And around sort of capacity and productivity, what's been sort of suggested moving now is that there's going to be 2.5 times fewer patients treated on a virtual ward that end up being readmitted. I think, to be perfectly honest with you, one of the struggles we have is the data set that we have to report on through a SITREG data. It's not very consistent, it's varied, and it's not very comprehensive in terms of the data it collects. So for us to be able to nail our cloth to the mat and say, yeah, we can see a reduction in readmissions, or we can see an improvement in terms of how it frees up capacity, I think it's really too early to say. But certainly moving forward, one of the things that we really want to take more control of is having an agreed data set. We can start having a much more transparent oversight in terms of the impact of virtual wards moving forward. And again, just in terms of, we have really positive staff feedback from teams who are doing virtual ward, multidisciplinary teams. And again, I think where it's technology enabled, again, what we actually see is some of the improvements there in terms of support and self-management. So the evidence is starting to come slowly but surely. Can we move to the next slide, please? I'm just going to give you a quick sort of snapshot of where we are in terms of year activity. So as I mentioned before, our big focus has been around frailty and respiratory. We had a target to have 640 beds capacity by March 2024. We're currently at 500, and the utilisation rate is about 40%. Now, that is significantly lower than the national average, and it's significantly lower than the NHS England's ambition of an 80% utilisation. What I would say to that is, I've looked at numbers across North East and Yorkshire ICBs, and the numbers of patients going through are not that dissimilar. But I think the big difference for us was when the planning was submitted for the number of beds we would have available, we are now measured against that original submission of 640 beds, and we think we were very over-ambitious. So I think that it's probably, those figures do us a disservice about what's actually happening on the ground. But certainly, from an NHS England point of view, those figures are something that often we get challenged with on a regular basis. So if you look at something like the frailty pathway, which is sort of the middle little block there, you know, the planned capacity for March is 375 beds. We're currently at 245, or what our trajectory is for that. But there's a 23% utilisation. And again, I think it's worth pointing out that the majority of our frailty pathways didn't start till April last year. And due to some of the challenges of getting those wards up and running, getting the right clinical guidelines in place, staffing, workforce in place, we didn't really get all the trusts live to frailty till December this year. So I think it's worth bearing in mind that this is still a really new concept. It's a really new model. And again, this is the challenge when you are measured against a performance target on something which is very much around an evolution and a bit of a journey as well. And again, for something like this to be embedded into a bigger system, it's always challenging. I'm sure we've all got experiences of that. And I think that's where we sit really with virtual wards. In terms of discharge destination, the majority of patients are discharged in their own place of residence. I'm pleased to say that in terms of admission to hospital, we're only showing something like 70% admission, which is really positive. In terms of length of stay, the average length of stay in a virtual ward is about 7.5 days, which is a little bit above the average for a physical bed, but I think that's to be expected. In terms of referral sources, you'll see that the majority of referrals are again from acute hospitals. That's the step-up type of model that we're talking about. And where we need to go is that shift now about how we start to have a much more fluent pathway and pathway interaction with other services as well, such as same-day emergency care, UTCs, primary care, and certainly with urgent community response. So if we move on to the next slide, please. So this is just to give you a quick snapshot really of what it looks like across Northeast North Cumbria. So as you can see, all the providers now have respiratory and frailty pathways. Some only have either a step-up model, or some might just have a step down, but most are moving towards both. You will see that some trusts are expanding their virtual ward programme and are piloting a number of different areas. Northumbria Healthcare is a really good example, and you can see there that they're focusing on a number of areas: TNO, lung cancer, and paediatrics. What I would say with those areas, the bed capacity is really low. They've only just tested it, so you might only be talking about 5 beds for TNO. And usually the utilisation is usually about 50%. So we are talking about small numbers, but it's an opportunity for us to learn from those providers who test those pathways, and then we can share that a part of our sort of governance arrangement across the system where we have an implementation group. We can share good practice there. We obviously inherited some pathways that have been around a long time. So if you look at Gateshead Health, they have had hospital at home, which is a really successful model that they've been run for a number of years, well before the national programme. So again, you have a little bit of mixture there, but certainly I think moving forward nationally, there's an expectancy now that ICS has moved towards more sort of age-appropriate pathways for children, such as maybe acute respiratory infections. Would like to see us move towards certainly looking at palliative and end-of-life care where possible, and heart failure as well, and colorectal. So again, interesting about how we think about moving that forward for the next oncoming years. Just next slide, please. Won't be able to read that, but basically the top sort of boxes about where we are now, and the boxes below about where we want to be. So what I've mentioned there really is where our current position is in terms of the number of beds we've got available and what our utilisation is and where we have those wards. Moving forward, and this is really the discussion really for today, it's really around how we start to align virtual wards as part of an integrated urgent emergency care model. how do we start to engage with not just our professional providers, but certainly a key player in terms of local authority. And I think also there's a real opportunity for third sector input into this as well. Certainly for people who are discharged from a virtual ward or are receiving care in virtual ward, there is a real opportunity there in terms of further ongoing support as well and linking in with other services. So I think for us, it's really around having a much more integrated model. So if we just move to the next slide, please. So this is just a very simple sort of diagram, but the right hand boxes there are really what we've got now, which is the core sort of offer, which is a referral to a hospital at home service or a virtual ward service, usually from secondary care as a step down model. And again, that will be about with 24/7 support and access where needed, combination of face-to-face and remote MDT support with access to diagnostics, and again, up to 14 days. Where we need to focus on is the right-hand element, which is really around where we start to think about how we are using single point of access services and triage services more effectively. And where can we be now joining up those dots with urgent community response, where then if a patient is needed, requires a step-up pathway, then there's a direct access into there from urgent community response, or that it might need to be bypassed and just go straight from a single point of access to a step-up pathway. So that's sort of the challenge we're at the moment. We have a small team that we've established of clinicians and managers across the area who are currently working on developing this model. And part of that, what we're trying to do now is build up a case for change, which looks at the risks, what the options are. And I think it's also recognizing that each place is different. Some parts of ICB will be able to move forward with this in a much more rapid way because they've got infrastructures that are fairly well connected. For others, it's going to take a little bit longer. So what we probably envisage that this model might be more tiered according to need and resources around each particular area, but based on those core principles that I talked about earlier. So that's sort of where we are at the moment. The next step really is for once we've got another couple of meetings with the clinical team during this month. And what we would then like to do is start to open up those discussions for the next few weeks to a wider audience and get further input. So again, anybody who's interested in being part of that or feels that there's some connections we need to make, we would love to hear from you. I think that would be really, really positive. And I think that's really about it for me at the moment. So I think if there's any questions, I'll do my best to answer them. I don't know whether that's been helpful or useful, but I would love to hear your feedback.
Tom, thank you so much. A brilliant presentation, and really struck by what this model could potentially do if we exploit it to its fullest, and what a difference that could make for patient experience and outcomes. We are really running out of time today, but I'm right in understanding, I think from what you've just said, that we could use this as just a segue into a broader conversation. And I think probably the wisest thing to do is invite you back once you've had those initial conversations you were talking about, and use this group as a way to engage further around shaping that proposal as we move forward as a system. So if there is anyone who wants to make a quick comment or question, we've probably got just about 2 minutes before we start to close this meeting, but we will invite Tom and Dan back, because I think this group has a key role to play in shaping this proposal. Claire.
Just really, I popped a note into the chat, but Tom, thank you very much for mentioning the possibility of working with third sector organisations in terms of virtual wards. We do have that happening here in North Cumbria quite effectively. British Red Cross are delivering it. If anybody wants to have a chat with me about what that looks like, please feel free to connect.
Yes, I've heard about that. I've heard great great stories about that. So that's a really good example.
Thanks, Claire. And I think that's probably a great way to bring this section to a close. And I'm sorry we didn't have more time for discussion, Tom, but hopefully this is the start of the journey with the collaborative. So thank you very much for joining everyone today. We have our next meeting scheduled for Tuesday, the 20th of February, and that is 12:30 until 2 p.m. We have shifted the focus for the next session based on the work we did on the retro board. So we will be hearing from Anna Krieber instead, along to talk about and share the work that Sunderland's doing on drug changers, and maybe if the timing feels right, maybe Tom and Dan would like to return and continue this conversation in our next meeting as well. But thanks ever so much for your contributions. We will also just briefly be looking at how we evaluate the impact of this group so far, and I think the next meeting is the last one we have scheduled, so we'll want to just have a little bit of discussion with you all about kind of next steps and whether you're happy to continue in this format. But thanks ever so much for joining and for your contribution today, and enjoy the rest of your Wednesday. Thanks, everyone.
Thank you.
Thank you.